Very good afternoon to one and all. My name is Dr. Karthik. I'm working as a senior resident in the Department of Anesthesiology at Sri Lakshminarayana Institute of Medical Science, Pondicherry. Today, the topic that I'm going to present is anesthesia for renal transplantation. So let's start with the topic per se. Coming to the introduction, in 1954, Dr. Joseph Murray performed the first successful renal transplantation on identical twins. Today, kidney transplantation is the most common organ transplant surgery performed. So, why is it so important? The 5 year survival on hemodialysis is worse than that of many cancers, compared to the 5 year survival patients of 89% following cadaveric transplantation and 92% for living donor transplantation. So, what are the indications? Indications are that it's usually indicated in patients with end-stage renal disease, which is defined as GFR less than 15, which is stage 5 CKD, which can be caused by any one of the underlying conditions. Number one is glomerular disease. It can also be caused by congenital diseases, and it can also be caused by tubular and interstitial diseases, polycystic kidney disease, nephropathies that are associated with hypertension, diabetes, and renal graft failure. Most renal dialysis patients are suitable for renal transplantation. What are the absolute contraindications? These can be anything varying from active systemic infection, uncontrolled active malignancy, severe cardiac or pulmonary disease, active drug abuse, or any uncontrolled psychiatric diseases. What are the relative contraindications? This can be morbid obesity, BMI more than equal to 40, and non-compliance with dialysis schedule or medication regimen, age greater than 75 years, patient has severe malnutrition, cachexia, they have multiple urinary tract reconstructions. HIV, as we see, is no longer an absolute contraindication to kidney transplantation. Recipient should be clinically stable on high active retroviral therapy, antiretroviral therapy, should be RNA negative and has a CD4 count of 200 cells per millimeter per greater. All right. The diagnosis of AIDS, which is a CD4 count less than 200 cells per millimeter cube, is a contraindication to receiving a kidney. So, what are the pathophysiology of end-stage renal disease? Let's start with the disorders of fluid and electrolytes. Initially, there's an onset of uremia and oliguria. This is followed by the expansion of the extracellular fluid volumes, followed by edema, hypertension, and signs and symptoms of fluid overload. This can be followed by disorders of the sodium, calcium, magnesium, and phosphate. There can be chronic changes in the bone metabolism, hyperparathyroidism, and vascular calcifications. Along with this, we will also see hyperkalemia, failure of the renal elimination of organic acids, which can lead to anion gap metabolic acidosis. Coming to disorders of cardiovascular system, the most common cause of morbidity and mortality in patients with ESRD is cardiovascular disease, which can lead to death in up to 35 to 45% of all patients receiving hemodialysis. There is increased risk of atherosclerosis, ischemic vascular disease, which can affect the coronary, cerebrovascular, and peripheral vascular systems. This can also be associated with hypertension, which can be the etiology of ESRD in nearly 30% of the patients. Conversely, hypertension may result from hyperrenemia, hyperolemia, renal vascular changes associated with ESRD. We can also see cardiorenal syndrome. We can also see pericardial disease, which is associated with pericarditis or pericardial effusion. Concentric elevation and diastolic dysfunction also seen. Dilated cardiomyopathy. Renal transplantation can improve the systolic function and reverse the left ventricular dilatation and hypertrophy. Coming to the changes in hematological system, these patients usually have normocytic normochromic anemia. This is predominantly due to lack of erythropoietin. They can also be exacerbated by iron deficiency, chronic inflammation, and bone marrow fibrosis. There can also be abnormal hemostasis, which is due to decrease in platelet activity, aggregation at the cells. Production of von Willebrand factor and factor VIII is decreased. On the contrary, ESRD is associated with the hypercoagulable state, increased fibrinogen levels, reduced antithrombin levels, acquired thrombophilic factors, and endothelial alterations. Risk of venous thromboembolism increases, which can also lead to DVT, pulmonary embolism, and thrombosis of AV fistulas and vasculitis capitis. Gastrointestinal system, there can be nausea, vomiting, and abdominal pain. There can also be delayed gastric emptying and dyspepsia. CNS changes are the mild changes in the memory or attention, uremia, which can lead to asexuous seizures and decreased mental status is also seen. There can also be associated peripheral neuropathy, which can be documented up to 90% of dialysis patients. Also, autonomic dysfunction, which is seen in 50% of dialysis patients, autonomic neuropathy, which can lead to orthostatic hypertension, cardiac arrhythmias, and gastric dysfunctionality. Kidney transplantation is the most effective treatment for the neurological manifestations of ESI. So let's classify the renal transplant by the donor organ source. So they can be related genetically to the patient. They can be paired or can be pooled. When more than two donors and two recipients will be involved in this swab. So the source of donor organ can be from a deceased donor or can be from a living donor. So deceased donor, this patient can be a non-heart beating patient or can be brainstem dead heart beating patient. Living donor can be related, unrelated. Unrelated will be the patient can be donating due to emotional connection, or if there's no emotional connection, we classify them to be altruistic, paid, and pooled. Coming to paid donor exchange transplant. The paid donor exchange transplant program is also known as kidney swap. Here, a pair of living donors may have an incompatible blood type or antigens to the intended recipient, but the donors agree to exchange the recipients. Each donor gives a kidney to an unknown but compatible individual. As a result, the donors provide two patients with healthy kidneys. So each patient receives a compatible graft. This, as you can see, will expand the pool of donors. Living donor transplant allows the recipient and donor surgery to be scheduled simultaneously. It offers the advantage of minimal organ preservation time. Short preservation time allows immediate graft function, high volume urine output, and initiation of creatinine clearance. Who's an ideal donor? Someone who's aged more than 18 years, who's ASA1 or 2, who can be normotensive. Hypertension is no longer a contraindication. Kidney function urine protein are normal. Creatinine can be less than 1.5 mg per DL. To ensure a sufficient reserve after donation, many transplant centers use a GFR greater than 80 ml per minute per 1.73 meters per as a cutoff for donation. The term expanded criteria donor has been introduced as part of an effort to increase use of kidneys that might otherwise have been discarded. Coming to expanded criteria donors, like we just discussed before, these are donors who are older than 60 years or 50 to 90 years. Two additional risk factors such as history of hypertension, death as a result of CVA, or serum creatinine, which is more than 1.5. There can be 70% increased risk of failure within 2 years compared with the standard criteria donors. Patients who are 40 years or older, especially with diabetic nephropathy and non-diabetic disease, but a long expected waiting time for kidney transplantation, show better survival receiving an expanded criteria donor kidney than remaining on dialysis therapy. Cadaveric donors. Donation after brain death. Brain death is defined as irreversible loss of function of the brain, including the brainstem. Donation after brain death, previously known as heart beating organ donation or donation after brainstem death, retrieval of organs after confirmation of death using brainstem death testing criteria. So, what is the goal of management here? It is to achieve physiological stability to ensure that the organs retrieved are in the best possible condition for transplantation. Invasive monitoring, close medical attention, donors should be cared for in the intensive care unit. So there are ethical conflicts surrounding the definition of brain death in different social and cultural settings, which have been obstacle in transplantation. So I'll give you a moment for you to observe and ask me any questions so far if you guys have any doubts. None so far? So shall we proceed? All right. Coming to management of brainstem dead donor. These are the, I'm here showing a table which is giving an overview of how we have the intraoperative management for a patient or in the ICU for someone who's a brainstem dead declared patient who's going to donate. So these are the cardiovascular targets. We can see that we have a particular set of heart rate that we would like to maintain, including systolic blood pressure, MAP, CBP, pulmonary artery wedge pressures, and SVO2s. So, what are the respiratory parameters that we would like to keep in such patients? How are the tidal volume, PEEP settings? What are the other settings with regards to intra fluid management? And how should be the renal and electrolyte balance for such a case? How should be the ideal urine output? And what should be the ideal temperature in such cases? All right, so let's move further. Donation after cardiac arrest. So donation after cardiac death refers to a donor who does not meet the criteria for brainstem death, but in whom cardiac sample occurs before the organs are retrieved. So two broad categories are there: uncontrolled DCD when death occurs suddenly and unexpectedly. Controlled DCD means when death occurs after the planned withdrawal of the life-sustaining treatment. Drawbacks that it obviously increases the warm melting. In the further slides, we'll discuss about warm and cold melting. The overwhelming majority of DCD organs are obtained from controlled DCD nodules, which follows the mass rich category 3 and 4. So this is the modified mass rich classification of DCD. We have 5 categories here. First category being dead on arrival, which will usually be in a patient received in a transplant center. Unsuccessful resuscitation, ED usually happens in the transplant center. Anticipated cardiac arrest, location is ICU and ED in transplant and non-transplant centers. Cardiac arrest in a brain dead donor. So again, ICU and ED. Unexpected arrest in ICU patient, ICU. Once again, as you can see. So these are the sequence of changes that can be seen in a DBD donor and DCD donor. So once the DBD means that there is a donor after brainstem death. So brainstem death is declared, donor is transported to the theatre, and initiation of organ preservation starts, organ retrieval, followed by cold storage and transport, removal from the cold storage at the recipient hospital. This is followed by anastomosis and reperfusion to the recipient. For the DCD donors, we withdraw the calc to a donor, and this is followed by cessation of cardiac activity. Donor is transferred to the theatre. Initiation of organ preservation starts. This is followed by retrieval, cold storage and transport, removal from the cold storage at recipient hospital, followed by anastomosis and reperfusion. So coming to matching, all patients to undergo immunological restrictions such as ABO blood group determination, tissue matching, and cross matching. Tissue matching relates to 6 specific antigen. This is called a major histocompatibility complex. Cross matching is a very sensitive test that predicts how a transplant recipient may respond to donor protein. Equivalent outcomes have now been demonstrated in living donors with complete mismatch due to the advent of immunosuppressive agents to those from deceased donors with zero mismatch. Coming to the matching process, blood group matching, ABO matching is usually done. HLA type matching, 6 antigens, the 3 loci, A, B, and D are usually matched. 6 antigen match is the best outcome. Immunocompression ensures favorable outcome for fully mismatched organs. Testing donor T cells against recipient serum, positive risk of hyperactive rejection. We can consider next potential recipient in such a case. Immunosuppression to prevent graft rejection comments in the preoperative period. The regimens comprise of 2 phases, which is induction and maintenance. The induction phase is typically administered pre and intraoperatively. Modern intraoperative regimens include a biological agent and high-dose methalprednisolone. Methalpred is administered around the time of venous anastomosis. Whilst many centers avoid use of long-term steroids for immunosuppression, almost all induction regimens include a perioperative dose. Coming to biological immunosuppressants. This is why induction of immunosuppression with a biological agent, which reduces the incidence of early cellular rejection, which balances against the risk of these extremely potent drugs. There are 2 groups, T cell depleting and non-depleting agents. Lymphocyte depletion is associated with cytokine release and potential drug reactions. Results in chronic immunosuppression in some patients, putting them at risk of infectious complications and malignancies in the long term. Depleting agents are only used when potent immunosuppression is required. This is when there is any HLA or EBV incompatibility between the donor and the recipient. Depleting agent examples are anti-thymocyte globulin and alemtuzumab. Intraoperatively, alemtuzumab usually 13 mg is given by infusion over an hour or by subcutaneous injection. Non-depleting agents, these drugs do not cause lymphocyte depletion but oppose the pathways that result in alloreactive T cell activation. They include CD25 antagonist, which is known as basiliximab. The benefit is of reduced immunoparesis and improved side effect profile, whilst reducing the risk of acute infection compared with regimens where injection agents are not used. Intraoperatively, basiliximab 20 mg is given solely by IV injection. Watch out for anaphylaxis and cytokine release syndrome, which is usually characterized by bronchospasm, hypotension, and tachycardia, which is initially distinguished from anaphylaxis, which is, if we see such a case, and it usually means that there is poor prognosis. So I'll wait for a while. If you have any doubts, you can ask here. Let's resume further. So what are the factors that affect the graft function? So the function of the graft is dependent on graft proficient foreign transplantation, whether there is a live or a deceased donor, the state of the kidney pre-donation, warm ischemia time, and cold ischemia time. So the aim is to limit the cold ischemia and warm ischemia time as much as possible here. So what is warm ischemia time? This begins when the donor vessels are clamped and is interrupted when the kidney is perfused with the cold preservative solution. Incidence of acute tubular necrosis increases with its duration. Should not exceed 3 to 5 minutes for live donors. Warm ischemia resumes when the kidney is placed in the recipient and terminates when the vascular anastomosis is complete, proficient by the recipient begins. What is cold ischemia time? This time begins when the kidney is cooled during harvesting and ends at the point where the core temperature is reached and proficient restored after the implantation. Earlier the kidney is transplanted, better the outcome, both in terms of delayed graft function and long-term graft survival. During cold ischemia time, the kidney is preserved by storing it at 4 degrees Celsius. Ideal cold ischemia time is 20 to 30 minutes. Cold ischemia time should be kept below 36 to 40 hours in case of cadaveric wounds. Although cold ischemia times greater than 36 hours are associated with poorer results, cold ischemia times as long as 72 hours have occurred with successful kidney transplants. Kidney from living donor may be flushed with preservative cold solution or ice ringer's lighter solution containing heparin and manitol. What are the cold storage solutions that we can use? Cold storage solutions, agents that do not readily permeate the cell membrane and have an electrolyte composition similar to that of an intracellular environment, which is low sodium, high potassium, thereby preventing the loss of cellular potassium. These are oxygen radical scavengers, which include the organ storage conditions. These are colons, urocolons, HTK, which is cheaper and commonly used, Celsior, Perfedex, and University of Wisconsin. Machine perfusion, another novel approach to improve and assessing organ viability, involves machine perfusion in a pod that pumps cold perfusion fluid through the kidney in a pulsatile manner. Particularly, it is useful for kidneys that have undergone ischemic damage during the retrieval. Studies have demonstrated that machine perfusion is associated with a reduction in DGF and superior graft survival at 1 year. Pre-op evaluation of donors. So the majority of donors are usually ASA 1 and 2. However, full preoperative assessment, including accurate measurement of renal function, is mandatory. Current guidelines for living kidney donation advises to accept healthy donors with an eGFR more than 90 ml per minute for 1.73 meters square. Donors are classified as complicated if they are older with multiple comorbidities, if they are obese with BMI more than 30, if they refuse blood products, if there are any vascular abnormalities, and require to have a right nephrectomy, which is surgically more demanding. Anesthetic management of a living donor. So we require standard non-invasive monitors, which are usually sufficient. 1 or 2 large bore peripheral intravenous lines are required here. The mode of anesthesia is usually general anesthesia, which can be employed for laparoscopic nephrectomy. In GA combined with epidural, open nephrectomy is planned. Open nephrectomy is usually via subcostal lateral incision. Left kidney is usually preferred because of the easier surgical exposure and longer vascular supply. Right kidney, which has a short vein and its artery courses posterior to the inferior vena cava, so it is less preferred. Position the patient's position in a lateral position with table flex and the kidney rest elevated. Anesthetic implications will be that of due to the laparoscopic surgery per se, where there is high intra-abdominal pressure, which reduces the venous return. This can be associated with post-operative renal dysfunction. Nitrous oxide is best avoided because of a concern over bowel distension and poor surgical exposure. Adequate IV fluid administration is the best strategy to preserve kidney function. We can employ liberal fluid strategy here at 10 to 12, 20 ml per kg per hour. Ensure that the urinary output is greater than 2 ml per kg per hour. Fluid is usually given in excess of the physiological need throughout the procedure. Furosemide and or mannitol during surgery for increasing the urine output. IV heparin up to 3,000 to 5,000 international units is often administered immediately before the renal vessels are clamped. Post-operative period, pain after open ectomy can limit the patient's effort to breathe, cough, and move, leading to atelectasis and post-operative infection. For post-op pain, IV opioids in the early post-op period and later with oral opioids and acetaminophen can be employed. NSAID should be used with caution because of the potential prostaglandin-mediated adverse renal effects. Post-op epidural analgesia can also be given. What are the long-term outcomes? Decrease of approximately 30% GFR can be expected after donation, and most donors will maintain a GFR greater than 60 ml per minute at 3 months. Donor nephrectomy does not appear to increase long-term mortality or end-stage renal disease. Likelihood of post-donation chronic kidney disease, hypertension, and diabetes is relatively higher. What is the pre-op evaluation of a recipient? So here, what is the challenges that can be expected in a recipient? As an anesthetist, we will see anemia. We can also see coagulopathy. We can see chronic liver disease, diabetes, hypertension, cardiovascular disease, pulmonary edema, delayed gastric emptying, immunocompromised state, peripheral anatomic neuropathy. So starting with the assessment of CVS, it is important to focus on the cardiovascular risk, assessing the coronary artery disease and cardiac function. Start with a baseline ECG, chest X-ray, and 2D echo. Non-invasive ischemic testing should be considered in candidates with 3 or more of the following risk factors. If there's any known cardiovascular disease, when there's diabetes, when dialysis has been going on for more than a year, age over 60 years, patient has tobacco use, LVH, dyslipidemia, and hypertension. What are the non-invasive testing options available? We can do a stress echocardiography with exercise or dobutamine, myocardial perfusion study, CT angiography can also be employed. So, who's eligible for transplantation? It's as per the Canadian 2005 Canadian Sessions for Transplantation Guidelines, which you follow. Following patients with known coronary artery disease may be eligible for kidney transplantation. We are either asymptomatic low-risk patients, asymptomatic patients in whom non-invasive testing is cited, patients on appropriate guideline-directed medical therapy with angiographic results showing acceptable burden of disease. Patients in whom successful revascularization interventions have been performed. Requirement for further invasive testing in patients who have strong evidence of cardiomyopathy with a low ejection fraction less than 30%. Cardiology evaluation and angiography. Patients who do not have evidence of cardiomyopathy in low ejection fraction obtain non-invasive testing if the patient is more than 45 years old and has diabetes mellitus or has a prior history of CT. So before we start, I'll wait for you people to have any doubts which we can clear before we move further for the assessment of our system. So, beginning with the assessment of the pulmonary system, increased prevalence of the occult pulmonary hypertension is a very important thing because 40% reported in one series occurs in patients receiving dialysis. The mechanism involves uremia-induced pulmonary vasoconstriction and increased cardiac output secondary to AV fistulas. So, pulmonary hypertension may be reversible after kidney transplantation. Right heart catheterization may be indicated in patients with evidence of significant pulmonary hypertension. How are the preoperative medications? Typically, patients are hypertensive. They might be on ARBs, ACV inhibitors, calcium channel blockers, alpha antagonists, or beta blockers. This impairs the autoregulation and undermines the ability to respond to hypovolemia and under anesthesia. AC inhibitors should be withdrawn perioperatively. Beta blockers, aspirin, and statins should not be stopped perioperatively. Diuretics should not be stopped as this may compromise native renal function after operation. Uremic state and frequent use of antiplatelet drugs in the population may impact platelet function and prolong bleeding times without abnormalities in the coagulation profile. As in all types of surgery, orally administered antihypertensive medication should be withheld in patients with diabetes. Absolute indications. So, should we dialyze patient preoperatively? Here, the absolute indications will be hyperkalemia, fluid overload, uremia, acidosis. A subtle balance should always be struck in such a case. Dialysis will reduce plasma potassium, correct acidosis, and potentially avoid the need for post-operative dialysis, even if graft function is delayed. However, it will render the patient intravascularly deplete, necessitating greater IV filling to optimize conditions for graft implantation. Hemodialysis is necessary on the day of surgery. We use heparin free dialysis to avoid intraoperative coagulation. Heparin has been used. We have to wait for 3 to 4 hours for the coagulation profile to return to normal. Since the half-life of heparin is 90 minutes. Targeting a post-dialysis weight that is 1 to 2 liter above the patient's usually target dry weight. Most transplant anesthetists operate by the idiom of in doubt, dialysis rather than dialysis in relatively small, if in doubt, dialysis basically to make sure that there's just, but obviously we have to make sure there's just small fluid shift. Immediate pre-op assessment. Look for disturbances in acid-base balance and electrolytes. Metabolic assist is a common problem in patients with end-stage renal disease. Estimation of the fluid status, severe hypervolemia to pronounced hypervolemia in patients undergoing renal transplant surgery. Blood glucose concentration should be managed. A level more than 160 mg per deciliter during reposition associated with delayed graft function after surgery. On the day of surgery, preoperative laboratory assessment of CBC, electrolytes KFT is necessary in all kidney transplant patients on the day of surgery. Increased potassium levels, especially with ECG changes, consistent with hyperkalemia, should prompt consideration for the delay of surgery and for immediate dialysis to correct potassium levels. Comparing the patient's current weight with known euvolemic weight or dry weight may be helpful. Patients who have preoperative body weights heavier than the euvolemic weight may have an excessive intravascular volume and may be at risk of congestive heart failure during the perioperative period. On the day of surgery, blood glucose levels should be measured. Insulin therapy initiated in patients before surgery for significant hyperglycemia. Serial blood glucose measurements during the perioperative period. Preparation of the patient intraoperatively. Intraoperative monitoring may be limited to standard non-invasive monitors and younger, healthier transplant recipients. Large bore IV venous access can be challenging some kidney transplant patients, as intravenous access may be limited by the presence of an upper extremity AV fistulas. We should do a Foley catheterization. Intraarterial blood pressure monitoring can be beneficial, especially in patients with uncontrolled hypertension, CAD, or heart failure. Radial arterial catheter used is placed contralateral to the pre-existing AV fistulas. Femoral access on the side selected for implantation is contraindication due to the risk of hematoma thrombosis adversely affecting the implanted graft. CVP monitoring, which is not a reliable monitor of the fluid status or responsiveness. The insertion of a central line provides reliable venous access for IV fluid resuscitation and transfusion. EC blood sampling, access for administration of immunosuppression drugs and vasoactive infusions. Patients without a pre-existing AV fistulas or dialysis catheter, central line allows urgent postoperative dialysis required. During patient positioning, any AV fistula is carefully protected to avoid pressure that may lead to thrombosis. So here we'll recruit. We'll wait for any queries so far before we proceed. Let's move back. So what are the anesthetic techniques that we can employ? And what is the preferred mode of anesthesia? GA with endotracheal intubation is the preferred technique. How about regional? Use of epidural combined spinal epidural anesthesia is controversial. Urinic bleeding tendency plus effects of residual heparin given during dialysis increases the risk of hemorrhage into the epidural space. Underlying hepatic disease alters the platelet function and decreases the coagulation factor levels. Intra-op management, what to anticipate during intubation. Patients with ESRD are considered at risk for aspiration of gastric contents, secondary to the presence of uremic gastropathy and other conditions such as obesity and diabetes. And oral non-particulate antacid and IV administration of H2 blocker may be considered before induction of anesthesia. Rapid sequence induction of anesthesia is the preferred method of induction for general anesthesia. Anesthesia is routinely induced with propofol or hyperbole. Succinyl choline, ascoline can be used safely in standard doses in patients with ESRD. And potassium levels are within the normal limits, usually less than 5.5 milligrams per liter. Potassium transiently increases from 0.5 to 1 milligrams per liter for 10 to 15 minutes before returning to the baseline levels in patients with ESRD, those with normal renal function. Modified RSI using rocuronium 0.8 to 1.2 mg per kg heavy may be substitute for scoline when hyperkalemia and other contraindications of scoline exist. Use with caution as the duration of action is prolonged here. Look for hypertension post-injection, especially in patients who have been rendered hypolimic from recent dialysis or patients receiving renin angiotensin blocking drugs. Maintenance of anesthesia. Maintenance typically performed using a combination of intravenous and oral anesthetics. Volatile inhaled anesthetics are titrated to the level of surgical stimulation. Desflurane and isoflurane are not associated with nephrotoxicity. Isoflurane is traditionally the inhalation agent of choice, as only 0.2% is metabolized. Although sevoflurane has potential nephrotoxic effects from the metabolites compound in fluoride, detrimental effects on renal function have not been demonstrated in patients with renal insufficiency. Analgesia during intraoperative period can be provided with synthetic opioids such as fentanyl, sufentanil, alfentanil, remifentanil because their pharmacodynamics are not affected by renal insufficiency. Morphine, oxycodone, meperidine should be sparingly used in patients with renal failure because these drugs have active metabolites that accumulate in these patients. Becuronium and rocuronium have prolonged duration of actions in renal failure patients because they rely both on the renal and hepatic metabolism. Cis-atracurium metracurium, the muscle relaxation of choice in patient in ESRD because it undergoes organ independent clearance. Pancuronium is primarily eliminated by the kidneys and probably should be avoided in patients with renal failure. NMDA should be titrated according to the degree of neuromuscular bucket with a peripheral nerve stimulator. For patients with ESRD who are undergoing kidney transplantation, judicious use of neuromuscular blocking drugs is a necessity. Titration to surgical conditions and close monitoring of the level of NMBs are crucial. This can be provided with IV paracetamol and incremental doses of fentanyl up to 1 mg per kg. NSAIDs are contraindicated because of the deleterious effects on the kidney function by the interruption of blood flow in the renal vasa. Management of hyperglycemia. We have to maintain an blood glucose target of 140 to 180 mg per deciliter. Avoidance of hypothermia. Maintain normothermia, temperature of more than 35.5 degrees Celsius. Maintenance of normothermia is important for optimal graft, optimal allograft perfusion. The adverse effects of systemic hypothermia include increased release of catecholamine, decreased graft perfusion, bleeding, prolonged response to NMDAs, adverse cardiac effects, and postoperative infection. Surgical steps. Usually, the right iliac fossa is generally preferred as a site for renal allograft. A vertical curvilinear incision of 20 to 25 centimeter long is typically made, extending from the pubic symphysis to the anterocipitally iliac spine. Two end-to-side vascular anastomosis performed of donor renal artery and external iliac artery and donor renal vein on iliac vein. Two end-to-side vascular anastomosis performed of donor renal artery and external iliac artery and donor renal vein on iliac vein. Following this, aortic anastomosis onto the bladder is usually performed. So, what is our rule during this time? We have to administer intravenous heparin, 2,000 to 5,000 units, which may be given before completing renal disease. Time when the vascular clamps are removed is a critical time for the anesthetic in terms of blood pressure and fluid management. During the anastomosis of the renal vessels, expansion of the intravascular volume with balance of solution should be initiated. Furosemide mannitol administered before reposition to stimulate diuresis. Which is the fluid strategy that we can employ. Liberal fluid strategy at the beginning of surgery is likely to be beneficial. Normal saline seems to be a logical choice as it is high in sodium and 3 of lactate and potassium. The mean arterial pressure of 90 mg is warranted for all patients undergoing renal transplantation because this preserves the renal function. After reperfusion of the allograft, maintain a higher MAP of more than 90. There's a good evidence that a CVP of 12 to 14 at the time of graft perfusion leads to improvements in the graft survival. Hypotension following reperfusion will result in hyperperfusion of the graft, and this can precipitate renal injury owing to ischemia and can contribute to the vascular thrombosis of the graft. Transfusion strategy, a transfusion target of 7 grams per deciliter or less than 8 grams per deciliter in patients with significant cardiovascular disease should be used before operation in line with the current recommendations. Should we use inotropes or not? Dopamine may be administered in the intraoperative and early postoperative period for 2 purposes. There is a theoretical benefit of dopamine receptor antagonists, which can improve the renal blood flow. A dose of 5 to 10 micrograms kg per minute, the beta adrenergic effects may help in maintaining the normal tension. For higher doses, the alpha adrenergic effects become dominant and blood flow to the graft kidney may be reduced. Similarly, alpha agonists such as phenylephrine cause large reductions in blood flow to the transplant kidney and should be avoided if possible. If hypertension still exists despite adequate filling, beta agonists such as globutamin and dopamine. How about colloid? In addition to isotonic crystalloid solutions, Some centers have administered 5% albumin to replace the blood loss on a 1:1 ratio until the transfusion threshold is met. Avoid hydroxyethyl starch solution because it increases risk of renal failure in critically ill patients. So, in extubation during emergence, exaggerated hemodynamic response are common, especially in patients with poorly controlled hypertension. So, we have to use of appropriate titration short-acting drugs to attend these responses in emergence is helpful. Careful neuromuscular blockade monitoring and appropriate administration of vessel agents are central to the avoiding a post-operative pulmonary complications. Sugammadex forms an inactive complex that is primarily cleared by the kidneys. Clearance of this complex is reducing ESRD patients, although removal of this complex using dialysis has been demonstrated. Sugammadex has been shown to be clinically effective in ESRD patients. However, its safety has not been demonstrated in kidney transplant populations. ESRD patients may demonstrate delayed emergence from anesthesia and have exaggerated response to opioids and sedative hypnotics. Extubation of the trachea should occur after the patient demonstrates the ability to protect the airway, because kidney transplant patients are still considered risk of aspiration and gastric contents at the completion of surgery. Coming to post-operative management, after extubation of the trachea, the kidney transplant recipient receives careful monitoring in the post-operative anesthesia cabinet. We have to monitor the urine output and as the intraoperative period, accurate fluid balance post-operative is essential. Fluid administration guided by urine output, CVPs, blood pressure, and daily weights. MAB less than 70 mm at any point during the postoperative period is associated with great TAP function. Acute decrease in the urine output, rapid evaluation of etiology and appropriate treatment should be instituted. DGF after transplantation normally as a result of acute tubular necrosis, secondary to the insult sustained due to report. Cold storage and reimplantation occurs more frequently in DCD than DVD kidneys. Coming to thromboprophylaxis, primarily as a result of comorbidities, patients undergoing renal transplant have moderate high risk of DVT. Early mobilization on the first post-op day is encouraged, and all patients should have anti-embolism stockings. Prophylactic heparin with low molecular weight or UFH can be employed until patient is mobile, although low molecular heparin is unlicensed in the UK for patients with an eGFR less than 30. The post-operative pain control, NSAIDs must be avoided as second class circumcision and reduced renal blood flow. Synthetic opioid analgesics without active metabolites can be used. Dose reductions are generally required in renal failure patients. Following kidney transplant, chronic pain conditions occur in 40 to 60% of dialysis patients. Pain controlled opioid analgesia is commonly initiated in the post-anesthesia care area and continue for 24 to 48 hours. Transversus abdominis plane block has been advocated for post-op analgesia in kidney transplantation. Results from RCT trials have been inconsistent. Early complications. Acute rejection can, however, occur in the early post-op period. This can manifest as either prolonged or delayed transplantation, deterioration of renal function. It's often accompanied by oliguria and pain with the transplanted kidney. Rejection is treated with high-dose steroids, alternative immunosuppressant regimens, or techniques such as plasma exchange to remove antibodies if appropriate can be employed. Vascular complications. The renal artery thrombosis presents within 48 hours of surgery. It can rapidly lead to aph loss and the need for allograft vasectomy. A kink in the renal artery, severe volume depletion, hypertension, and prolonged vomiting can make risk factors. Renal vein thrombosis occurs within the first week after transplantation. Clinical presentation includes sudden oliguria or anuria, graft tenderness, swelling, hematuria, and ipsilateral low limb edema can also be seen. Duplex ultrasound can be employed if any clot is visualized and urgent re-exploration is required. Significant bleeding from the vascular anastomosis is rare, but can be dramatic and life-threatening. Manifestations as severe hypertension, hypotomic shock, release. Urinary complications such as urine leak or ureteric stricture causing hydronephrosis occur in approximately 5% of patients. RRTs, multiple modalities of RRTs may be used in management of critically ill patients with kidney failure. These include CRRTs, intermittent hemodialysis, and prolonged intermittent renal replacement therapies. So, CRRT and PRRT are most commonly used in hemodynamic unstable patients. CRRTs, various techniques that can be used are CVVH, CVVHT, CVVHTF, which is continuous veno-venous hemodiafiltration, and SCUF. So, we have a brief idea about the various modalities, which is not currently necessary for this topic, but I've just highlighted here. And these are the basic mechanisms for the various CRT techniques, which can be dealt with later on a separate section. Timing of initiation of RRTs. In the absence of specific indications, the optimal timing of initiation of RRT in AK is uncertain. Early initiation of RRT in AK was for optimization of volume status, early correction of acid-base balance, and alkaline disturbance, and control of histamine. However, the potential benefits of early initiation need to be balanced with risk and burdens of RRT per se. Multiple observational studies have suggested improved survival associated with early initiation of RRTs. So, discontinuation of CRRTs, there are no specific criteria for discontinuation of CRRT because of recovery of kidney functions or transition to other modalities of RRT. In the beginning and ending supportive therapy for kidney study, which was a elaborate study, urine output more than 400 ml per day without concomitant diuretic therapy was predictor of success. In the 18 acute renal failure trial network study, RRT was continued if the measured creatinine clearance was less than 12 ml per minute, was discontinued if it's more than 20 ml per minute, and was left to clinical judgment if the measured creatinine clearance was between 12 to 20 ml per minute. Okay. Transition from CRRT to PRT or IHT may facilitate initiation of physical therapy and mobilization out of the bed. In general, patients with persistent RRT dependent AKI must be transitioned to IHT prior to ICU discharge. So this is a summary outlining the anesthetic management of renal transplantation. Starting with the preoperative management, we have to obtain a full history, consider anemia and plasma blood, basic maintain patient on dialysis, have a look on acidosis states, alkalosis, hyperkalemia, avoid hypokalemia, correct the hyperkalemia and acid-base abnormalities. We can use beta blockers, CCBs, alpha blockers, diuretics, statins, omit AC inhibitors, and angiotensin 2 receptor antagonists on the day of surgery. These are the investigations that we can consider, and we also have to consider delayed gastric emptying. Post-operative care, administer supplemental oxygen, provide analgesia with fentanyl PCAs or any other IV opioids of your institution preference. Monitor the arterial interval pressure to guide fluid administration. Monitor urine output. Avoid hypolemia and consider blood transfusion history. Do not unnecessary insights. Again, this is an overview that I've taken from NICERA for perioperative management of renal transplantation. Considering starting from anesthesia, induction, monitoring, maintenance, fluid therapy, and immunosuppression. This is basically an overview of what we have studied so far. So if you have any doubts, we can wait further or we can finish the class right here. So thank you for your patiently listening to this class. Thank you.